The first chapter lymphatics. First embryology and anatomy. In embryology, you have to remember about 3 weeks. Okay, one is 6th week. What is happening in 6th week? What is happening in the 8th week? And what is happening in the 9th week? Okay. So 6th week, the primordial lymphatic system is first seen during the 6th week of development in the form of lymph sac located next to the jugular vein. First MCQ. Second MCQ is during the 8th week, where cisterna chyli forms just dorsal to the aorta, and at the same time, 2 additional lymphatic sacs corresponding to the iliofemoral vascular pedicle begin forming. So main next is your communicating channels connecting the lymph sac, which will become the thoracic duct, developed during the 9th week. So your primordial lymphatic system is developed during 6th week. Okay, cisterna chyli 8th week and thoracic duct 9th week. That is MCQ. So next, you see in the diagram 66.1. These are the major anatomic pathways and lymph node groups of the lymphatic channels. How these interconnections are forming. Okay, so if suppose failure of one of the internal jugular lymphatic sac to develop proper connections and drainage with the lymphatic system, okay, and subsequently to the venous system may produce a focal lymph cyst called cavernous lymphangioma, okay, also known as cystic hygroma. So you have to know about the definition, 3 definitions. What is cystic hygroma? What is simple capillary lymphangioma? And what is primary lymphedema of the extremities? So how it is formed? How these 3 are forming? Okay, first is cystic hygroma. It is your failure of one of the initial jugular lymphatic sac to develop proper connections and drainage. Okay, with the lymphatic system, subsequent venous system, that will form a cystic hygroma. So how the simple capillary lymphangioma is forming? So failure of embryogenic remnant of the lymphatic tissues, okay, to connect to efferent channels lead to the development of cystic lymphatic formations. That is a simple capillary lymphangioma. So they are further classified into the lymphangioma classified into truncal, mesenteric, intestinal, and retroperitoneal lymphangiomas. Okay. So number 3rd is primary lymphedema of the extremities. How the primary lymphedema of the extremities forming? So hypoplasia or failure of the development of drainage channels containing the lymphatic system of extremities to the main primordial lymphatic system of the torso. Okay. There is a connection problem between the leg and the torso. Okay, associated with the hypoplasia and failure of development of that torso lymphatic systems. Primary lymphedema of the extremities. Okay, so 3 things: cystic hygroma, simple capillary lymphangioma, and primary lymphedema of the extremities. Then we go to the what is the genetics behind. Okay, so what are the growth factors that behind the lymphangiogenesis? Okay, the lymphangiogenesis is regulated by the vascular endothelial growth factor C, D, and VEGFR3 and their binding protein neurophilin 2. Okay, a very important MCQ: VEGFC, VEGFD, VEGFR3, and neurophilin 2. Okay, so in that the VEGFR3, okay, it is associated with the Milroy disease. Just remember, Milroy disease is the your congenital familial lymphedema. Okay, congenital familial lymphedema is otherwise called Milroy disease. So VEGFR3 is associated with the congenital Milroy disease. So next, what are the other genes? Okay, the 3 genes are very important. One is FOXC2, another one is SOX18, another is RAMP1. Okay, so FOXC2 is associated with the hereditary lymphedema distichiasis syndrome. Okay, distichiasis syndrome. Okay, this MCQ is in wise. Okay, what is gene associated with the hereditary lymphedema distichiasis syndrome? Okay, that is FOXC2. Okay, and what is the genes responsible for hypotrichosis lymphedema telangiectasia? Okay, that is your SOX18. Okay, the SOX18 related to the hypotrichosis lymphedema telangiectasia. And what is RAMP1? So RAMP1 is also important factor for lymphangiogenesis. Okay, they have found that RAMP1, okay, mutation is found in surgery associated lymphedema. Okay, surgery associated lymphedema. Okay. Okay, so you have to remember. So RAMP1 is also lymphagenesis and is more associated with the surgery associated lymphedema. Okay, so these are the genes. First, VEGF-CD, VEGFR3, and NRP2 is responsible for lymphangiogenesis, and another FOXC2, what is the disease? SOX18, what is the disease? And RAMP1. Okay, and then there's function and structure. So function and structure, the lymphatic system consists of 3 elements. One is initial or terminal. Okay, initial or terminal lymphatic capillaries which absorb the lymph, and second one is the collecting channels, which primarily serves a conduit for the lymphatic transport. Third one is the lymph node, which are interposed in the pathway of the connecting channels, filtered lymph, and serving as a primary immunological role. So three things. One is initial and terminal lymphatics. Second is collecting vessel. Third is lymph node. Okay. First is about terminal lymphatics. The terminal lymphatics have special structural characteristics that allow entry not only of large macromolecules but even of cells and microbes also. Okay. So next and all story only. Next, they will after the terminal lymphatics, it will go into the collecting vessels. Okay, from the collecting vessels, it will drain into the main lymph channel of the torso. Okay, this lymph channel empty into the venous system through the thoracic duct. Okay, so this is order. The order they will ask. Okay, first is terminal lymphatics, collecting vessel. Okay, so main lymph channel. Okay, followed by thoracic duct, followed by venous system. Okay, and there is a connection. There is additional communication between the lymphatic and the venous system. These smaller lymphovenous shunts mostly occur at the level of the lymph node and around major venous structures such as jugular, subclavian, and iliac veins. Okay, this is very important MCQ. So lymphovenous shunts where is it present at the level of the lymph node and around the major venous structures such as jugular, subclavian, and iliac. So these are the 4 areas where lymphovenous shunt present, and several structures in the body that contains no lymphatics. Very, very important MCQ. Structures containing no lymphatics. What are the structures? One is epidermis, cornea, CNS, cartilage, tendon, muscle. Okay. So next is your lymphatic system. The lymphatic functions of the lymphatic system.
Page is over zoomed. Okay.
Okay. The lymphatic system has 3 functions. Okay. One is ultrafiltration. Number second is immune system. Number third is fat absorption. Okay. Shortly, I have explained. One is ultrafiltration of the macromolecules and tissue fluids. Number 1. Second is immunological mechanisms, that killing of the microbes, antigens, that and all. Third is fat absorption. Okay. So next paragraph is very important. In contrast to what happens, the venous forward flow. Okay, lymph centripetal transport occurs. The lymph centripetal transport occurs mainly through intrinsic contractility of the usual lymphatic channels. Okay, so they will ask in MCQ, what is the main factor responsible for lymph flow? They will give intrinsic contractility of the individual lymphatic vessel, or they will give surrounding muscle activity, or negative pressure secondary to breathing, or transmitted arterial pulsation. Okay, so among these, the main action is mainly through intrinsic contractility of the individual lymphatic vessel. Okay, so and the other 3 things are lesser role, such as surrounding muscle activity, negative pressure secondary to breathing, and transmitted arterial pulsation have lesser role. Next is pathophysiology and staging. The pathophysiology and staging. So they mainly deal with the lymphedema now. The lymphedema is the result of the inability of the existing lymphatic system to accommodate the protein and the fluid entering the interstitial compartment at the tissue level. So okay, the impaired lymphatic vasculature can be either aplastic, hypoplastic, and hyperplastic. Okay. So next is in aplasia and hypoplasia. Aplasia means absent. Hypoplasia means decreased number of lymphatic channels. But in hyperplasia, the vessels are incontinent and tortuous. Not overgrowth of the increased number of lymphatics. Hyperplasia means the vessels are incontinent and tortuous. Okay. So this next percentage is very important. Hyperplasia is only a cause in 8% of the patient lymphedema. Okay. So all the lines are important in this chapter. Okay. All the points are MCQ. Okay, line to line. Very small chapter. Next is so what are the different phases of clinical stagings of the lymphedema? Okay, one phase is called in the latent phase. The latent phase, excess fluid accumulates and the lymphatics become fibrous. So in the latent phase, there is no clinical evidence of edema. Okay, so just to remember, in the latent phase, there is no clinical evidence of edema. Next, what are the different stages? There are 3 stages: first stage, second stage, third stage. Okay, the first stage, what will happen? The first stage, the patient will present clinically with a pitting edema. The second stage, the patient will present with a non-pitting edema. Okay, non-pitting edema has a spongy consistency, but main key point here is elevation does not reduce the edema, and skin fibers is more apparent. Okay, in type 1, the edema will decrease on elevation. Okay, slightly, but in type 2, stage 2, the elevation does not reduce the edema, and skin fibers is more apparent. Okay, finally, the third and most advanced stage of lymphedema, which is have the ulceration, skin changes. Okay, fibrosis, scarring with the associated severe skin changes characteristic of lymphostatic elephantiasis. Okay, so edema is irreversible in this stage. Okay. Okay. So do you see the difference in the word? Okay. So elevation does not reduce the edema. It means it is stage 2. Edema is irreversible means it is stage 3. Okay. Third stage or advanced, most advanced stage. Next, differential diagnosis. So differential diagnosis. Okay. So first they are telling that in most patients with the second or third stage lymphedema, the characteristic findings of critical examination can usually establish the diagnosis. Okay. So what are the characteristic findings? Okay. There is a firm and hardened consistency. So here you have to see about 3 findings. Okay. 3 named MCQs. One is tree trunk pattern, buffalo hump, and stemmer sign. So everything is depicted in the diagram, figure 66.2. So what is a tree trunk pattern? There is a loss of the normal perimalleolar shape, resulting in a tree trunk pattern. So what is buffalo hump? The dorsum of the foot is characteristically swollen, resulting in the appearance of the buffalo hump. What is stemmer sign? The toes becomes thick and squared, known as stemmer sign. Okay, so these are the things we have seen in case of second and third stage of lymphedema. But what is in case of advanced lymphedema? The skin undergoes characteristic changes. Very, very important MCQ. What are the characteristic skin changes? One is lichenification. Second one is development of the pudgy orange. And the third is hyperkeratosis. Okay. So lichenification, pudgy orange, hyperkeratosis. These are the skin changes in the advanced lymphedema. Next,
In daily summer sign, they have given us unable to pinch the skin, no?
Daily.
Okay, okay.
And this they are telling one fact. What is that fact? Is the patient with the isolated lymphedema, okay, usually do not have the hyperpigmentation or ulceration. One typically sees in patient with the chronic venous insufficiency. Okay, and just note it down. So then lymphedema does not respond significantly to overnight elevation, whereas edema, normal or edema, cellulitis, lymphangitis, that edema secondary to central organ failure or venous insufficiency does. Okay, so lymphedema do not respond to elevation, and edema secondary to central organ failure or venous insufficiency does. So next paragraph. Okay, the most common cause of bilateral ischemic edema are of systemic origin. Okay, what is the most common cause for the systemic origin is cardiac failure. The most common cause of bilateral edema is cardiac failure, followed by renal failure. MCQ. The next is how do you differentiate between the lymphedema and the lymphedema? Okay, so what are the characteristic bases of lymphedema? Okay, so lymphedema is not true edema, but rather excessive subcutaneous fat typically found in the obese woman. So, okay, excessive subcutaneous fat typically found in the obese woman. It is bilateral, non-pitting, greatest with the angle and the legs. Okay, with the characteristic sparing of the feet is very, very important. And there is no skin changes. The enlargement is not affected by elevation. Okay, the history usually indicates that this has been lifelong problem that runs in the family. All points are very important. 6 points they have told. One is excessive subcutaneous fat typically found in the obese woman, bilateral non-pitting greatest with the angle and leg and ankles, sparing of the feet, no skin changes, enlargement is not affected by elevation. Okay, the history that runs in the family. Okay, other keywords for lymphedema. Okay, and next, so how to differentiate from the venous disease? Venous edema. Okay, the venous disease is overwhelming the most common cause of unilateral leg edema. First MCQ. Okay, the most common cause of unilateral leg edema is venous disease. Okay, so leg edema secondary venous is usually pitting. Okay, and it's greatest at the ankle and the legs with the sparing of the feet, similar like lymphedema, but it is pitting. Okay, the edema responds promptly to overnight leg elevation and is controlled with the regular compression. Okay, so the response promptly to overnight leg elevation and is controlled with regular compression. So in the later stages, the patient with the skin is atrophic, brawny edematous, brawny pigmentation. Okay, ulceration is usually associated with the venous insufficiency occurs above or posterior to and beneath the malleoli. Okay, these are the characteristic findings of venous edema. Okay, so next classification. Lymphedema is classified as primary, secondary. Okay, the primary lymphedema can be classified into based on the year of onset, okay, age of onset, into congenital lymphedema, lymphedema precox, lymphedema tarda, 3 types. Congenital lymphedema, lymphedema precox, lymphedema tarda. So lymphedema, congenital lymphedema, when you get congenital lymphedema, the primary lymphedema, the onset before the first year of life is called congenital lymphedema. And 1 to 35 years of age, that is precox, and more than 35 years is tarda. Okay. The familial version of congenital lymphedema is known as Milroy's disease, and is inherited as a dominant trait. So like that, the familial version of precox is mixed disease. Okay. Okay. So next, more than 35 years is your tarda. Okay. So the next, the important MCQ is among these 3 things, which is the most common form of primary lymphedema. Okay, we will think that it is congenital. It is not congenital. It is precox. The precox is the most common form of primary, which constitutes about 80%. So then next, congenital and tarda lymphedema accounts for 10%. Okay. So next, another 2 important statements. Okay, what is the most common cause of secondary lymphedema worldwide? Worldwide, the most common cause of secondary lymphedema is your filariasis. Okay, which is Bancrofti. Okay. Okay. And in what is the most common cause of secondary lymphedema in developed countries? See the difference. One is world is filariasis, and the developed countries is dissection or ablation of the regional lymph node by surgery. Okay, or radiation therapy or tumor invasion or direct trauma, less commonly an infectious process. Okay, so in developed countries, most common cause you keep it as dissection, surgical trauma. Okay, during lymph node dissection. Okay? And diagnostic test. Let's come to diagnostic test. So diagnostic test, the lines of lymphedema is relatively easy. Okay, in patients with the 2nd and 3rd degree of disease. Okay, so difficult to diagnose the first stage. I already know. Now the MCQ point is, what is the diagnostic of choice in patient with the edema of unknown cause and a suspicion of lymphedema? Is your lymph scintigraphy. Okay, here you have to know about 2 important investigations. One is lymph scintigraphy, and another is lymphangiography. Okay, one is
page is not changed.
Okay. First is lymph scintigraphy. So lymph scintigraphy. So first, second paragraph, lymph scintigraphy or isotope lymphography. So just to note the word isotope lymphography is another term for lymph scintigraphy. As emergency test of choice in patient with the suspected lymphedema. Okay. So what I have previously learned, that the same thing only. Okay. Test of choice in patient with the suspected lymphedema is lymph scintigraphy. Okay. What is the disadvantage of this lymph scintigraphy? It cannot differentiate primary and secondary lymphadenoma. Okay. But it has more sensitivity, 90% sensitivity, and specificity nearly 100%. Okay, in differentiating lymphadenoma from other cause of the lymph swelling. That is his main advantage, but his disadvantage is it won't tell you whether it is primary or secondary. Okay. Okay, the advantage of this, another advantage is very simple, safe. Okay, and it's very small exposure to the radioactivity, 5 microcurie only. Okay, so what are the radio-labeled techniques, radio-labeled agents we are using is, one is radio-iodinated human albumin. Just wrote the term iodinated human albumin or technetium 99M labeled sulfur colloid. Okay, so here you have to know about what is the agent and where we are injecting is very important. What is the inference? So the agent is the human albumin and the sulfur colloid, technetium 99 sulfur colloid, and where we are injecting is first the interdigital space of the foot or hand, depending upon the upper limb or lower limb. Okay, first interdigital space. Okay, so and what you have to know inference is, you have to measure the amount of radioactivity at the inguinal nodes, 30 and 60 minutes after injection of the radiolabeled substance of the feet. The uptake of value that is less than 0.3. Okay, for the total injected dose 30 minutes is the diagnosis of lymphedema. So less than 0.3% is lymphedema. Wow. Then what is a normal range of uptake is 0.6 to 1.6%. Okay, so normal is 0.6 to 1.6%. If it is less than 0.3%, then this lymphedema is diagnosed. Then when to say is a secondary to venous disease. In a patient with edema secondary to venous disease, isotope clearance is usually not abnormally rapid. Okay, resulting in more than 2% ileoinguinal uptake. Okay, usual ileoinguinal uptake, it will be given more than 2% of the ileoinguinal uptake. Okay, in case of venous edema. Okay, these are the 3 inference. Okay, point less than 0.3, 0.6 to 1.6, and what is more than 2%. Okay, very important inference. Okay, importantly, so they have given a statement, a last line. Importantly, variation in the degree of edema involving the lower extremity does not appear to significantly change the rate of clearance of the isotope. Okay, over this true or false statement. Okay, and next, these are the various points related to the lymphocytography. Then we'll go to the direct contrast lymphangiography. Okay, it gives the finest details of the lymphatic anatomy, but it is invasive study. Okay, so where we are injecting the contrast is in the dorsum of the forefoot. In the lymphocytography, we inject the interdigital space, first interdigital space. Here, dorsum of the foot. What is the agent is your ethiodoacid oil. Okay, ethiodoacid oil is we are using here contrast medium. Here the contrast medium is ethiodoacid oil. Okay, so. So they are telling that after the cannulation of the superficial lymph vessels, the contrast is slowly injected into the superficial. A total of 7 to 100 ml of contrast is ideal for lower extremity evaluation. So lower extremity evaluation, you have to use 7 to 10 ml. Upper extremity just half of it. Okay, 5 ml. Just remember 10 ml, 5 ml. Okay, but the disadvantage of this is potential complication to the including damage of the visualized lymphatics, allergic and pulmonary embolism if the oil-based contrast agent enters the venous system. Okay. To the lymphovenous anastomosis. These are certain disadvantages. So mainly in the direct contrast lymphangiography, you have to know about where we are injecting, what we are injecting, then how much is the maximum amount for upper extremity, lower extremity. Then now where we are using lymphangiography. This lymphangiography is present surgical practice is used infrequently and slowly served for the preoperative evaluation of selected patients who are candidate for direct operation on the lymphatic vessels. So this they can ask. Okay. So what is the investigation we are using for candidates for direct operation on the lymphatic vessels in the preoperative? You have to give lymphangiography. Okay. So what are the other new diagnostics? The two other new diagnostics they are using. First one is the most promising new test appears to be the contrast MRI, contrast MR lymphangiography. Okay. So what we are the contrast agent they are using is gadobinate dibeglutamine. Okay, gadobinate dibeglutamine. Okay, they are using that. Where they are injecting some mode is your intracutaneous injection. Okay, intracutaneous injection this contrast agent in the interdigital webs of the dorsal foot. Okay, similar like scintigraphy. Okay, so contrast agent is gadobinate dibeglutamine, the intracutaneous injection. So number second.
Is not visible.
First one is your MR contrast MR lymphangiography. So what is the contrast medium where we are injecting? Next one is bioimpedance spectroscopy. So bioimpedance spectroscopy mechanism is based upon the electric current. In a particular region of the body is mostly related to the amount of fluid in the tissue. Okay, with the early lymphedema and interstitial fluid impedance increases. This is inference. Okay. So when tested in small samples, sensitivity specificity has found to be 100%. This bioimpedance spectroscopy. Okay, highest sensitivity, highest sensitivity specificity. Okay, bioimpedance spectroscopy. Okay, so next is your therapy treatment of the lymphedema. So in that many treatments are available. In that generally they told that we currently have no effective medication for the treatment of lymphedema. First, general therapeutic measures. In that, you have to give appropriate antibiotics directed to the gram-positive cocci. So eczema, you have to treat eczema by using hydrocortisone-based creams. So next, elevation and compression garments. In that, you have to use high-quality elastic garments. Okay, you have to use in all the times except when the legs are elevated above the heart. Okay, so what is the pressure range in the ideal compression garment pressure is 30 to 60. Okay, 30 to 60 mmHg. Okay, if suppose you want to elevate the leg, how much you have to elevate means you have to raise the foot of the bed on 50 centimeter block. Okay, so you have to use 15 centimeter block. That much leg raise is needed while sleeping. Okay. So next is complex decongestive physical therapy. So there is complex decongestive physical therapy is different and compression pump therapy is different. Okay, so complex decongestive physical therapy. So here they are here. What is the first MCQ is what is the steps of this complex decongestive therapy? First, they will touch the normal limb. Okay, if suppose unilateral leg limb is present, unilateral lymphedema is present. Okay, they will go to the contralateral normal limb first. Okay, they will massage the area first. The technique is initiated on the normal contralateral side of the body, evacuating the excessive fluid and preparing first the lymphatic zone of the non-affected extremity, followed by the zone in the trunk quadrant adjacent to the affected limb before attention is turned to the swollen extremity. Okay, so then only they are being finally they are coming to the affected extremity. In the affected extremity, the first segment they are massaged is the proximal zone. Massage starts from the proximal zone and proceeding to the distal limb. Okay. Yeah, we will think that the lymphatic flow is from distal to proximal. So we will first massage the distal part and we'll go to the proximal. Not like that. First we have to massage the proximal part. Then we'll go to the distal part. That is MCQ here. Okay. So this kind of therapy is appropriate for patient with all stages of lymphedema, true or false statement. Okay. And we can use complex deconstruction all stages. Okay. So what are the different stages? The two stages, initial or reductive stage first, then is the maintenance phase. Okay. So the patient undergoes daily to weekly massage session for up to 8 to 12 weeks. Initial, that is initial or reductive stage. And for maintenance massage treatment every 2 to 3 months, while continuing to wear the compression garment. That is maintenance phase. Okay. So what is the volume reduction? Final volume reduction is generally 60 to 70%, and compliant patient retain 90% of this reduction. Okay. So compression pump therapy. The compression pump therapy, when you have to use is when a patient with advanced lymphedema is first preferred for second paragraph. First preferred therapy, an initial approach with hospitalization for 3 to 4 days involving stick limb. First you have to do a stick limb elevation for 3 to 4 days. Followed by you have to do daily complex decongestive physical therapy. Then only you have to go for compression pump treatments, maybe necessary. Okay. Okay. Directly you could not go for compression pump therapy. Okay. That is MCQ point here. There is no MCQ. So drug therapy is very, very important. The two drugs they are using, one is benzopyrins, and another one is diuretics. So benzopyrins is very important MCQ. So what is a benzopyrins? The benzopyrins, the class of medication including coumarin. Okay, 1,2 benzopyrons. Okay. So what is the mechanism of action of this benzopyron is stimulation of proteolysis by tissue macrophage, and stimulation of the peristalsis and the pumping action of the collecting lymphatics. Okay. Collecting lymphatics. Just remember, not the terminal lymphatics, it is the collecting lymphatics. Okay, and benzopyrins has no anticoagulant activity. Okay. So usually coumarin having your anticoagulant activity, but in the benzopyrons, usually this has not having any anticoagulant activity. Okay. What are the other, apart from the lymphedema, decreasing the size of the lymphedema, what is the other advantage of this drug is it is decreasing your skin temperature and it is decreasing the attacks of secondary acute inflammation and discomfort of the lymphadematous extremities and the skin trigger. Okay, skin trigger and supplements were improved with the coumarin. Okay, skin trigger and the supplements will improve with the coumarin. That's it. Then we go to the diuretics. The diuretics may temporarily improve the appearance of the lymphadematous extremity. The stage 1 disease, very, very important, leading patients to request continuous therapy. Okay. So, however, other than producing temporary intestinal depletion, there is no long-term benefit as lymphedema fluid is. There is a long-term benefit as lymphedema fluid is not in the vascular space. Thus, diuretics has no role in the treatment of lymphedema at any stage. Okay. So, thus, diuretics has no role in the lymphedema at any stage. Okay. Next is molecular lymphogenesis. So, what is molecular lymphogenesis? In that, based upon this VEGFR pathway, okay, they are identifying some molecular drugs, okay, by attracting the VEGFR3 pathway by administration of cognate ligands, VEGF-C and VEGF-D using a variety of methods. That's it. Just remember VEGFR pathway. Okay, they are targeting the VEGFR pathway. So next, operative treatment. So operative treatment, before operative treatment, you have to know about what is the percentage of non-operative treatment. Okay, 95% patient with lymphedema can maintain it non-operatively. Okay, so what is surgical intervention? Indication of surgical intervention considered for stage 2 or stage 3 lymphedema who have severe functional impairment, recurrent episodes of lymphangitis, and severe pain despite optimal medical therapy. Okay. So two main categories of operations are available for the care of the patient. One is a reconstructive method and the excisional method. The two methods, one is reconstruction method and excisional methods. What is the reconstruction method? The reconstruction method should be considered for those patients with the proximal obstruction of the extremity lymphatic circulation with preserved dilated lymphatics peripheral to the obstruction. Okay, we have to have some peripheral remaining lymphatics. Then only you have to go for reconstructive operations. So reconstructive operations, some of the most common candidates for reconstructive procedures are patient with upper extremity lymphedema, secondary to axillary lymphadenectomy, or patient with leg lymphedema, secondary inguinal pelvic lymphadenectomy. So wherever the iatrogenic lymphadenectomy injury, lymphadenoma followed by iatrogenic injuries, we can go for these reconstructive procedures. Okay. So what are the various reconstructive procedures? One is lymph. You can see the diagram 66.4. So first one is lymphovenous anastomosis. So what's the A diagram is your venous interposition graft. Okay, we can keep on the venous graft. And the second is your lymphovenous anastomosis. Okay, and the third is your invagination of multiple lymphatics in your vein graft. So these are the various methods. Okay, so then is the excisional procedures. The excisional procedures. What is the prerequisite for excisional procedures? Is only viable option for a patient without residual lymphatics of adequate size for reconstruction. When reconstruction is not possible, you can go for excisional. So indication for patient with a recalcitrant stage 2 or early stage 3 lymphedema in whom the edema is moderate and the skin is relatively healthy. Okay, see the word recalcitrant stage 2 and early stage 3. Edema only is moderate. You have to have a moderate edema and the skin is healthy. Then only you can go for this excisional procedure. Okay, that removes the excisional procedure that removes a large segment of lymphedema subcutaneous tissue and overlying skin is the procedure of choice. Okay, you have to remove the subcutaneous, remove the procedure. This is the procedure of choice. What is the procedure name? Is called Contolian. Okay, Contolian procedure. It was later it was described by Homan. Okay, has staged subcutaneous excision underneath flaps. Homan's procedure. Okay, so that is given that figure 66.5. This figure itself asked many times in wise. Okay, what is the procedure? Is it a Contolian or Homan procedure? We can tell like anything. Okay, so what is the procedure? Okay, so this procedure, this operative approach start very you have to give the incision, medial incision extending from the level of the medial malleolus through the calf to the mid thigh. Okay, medial malleolus through to mid thigh you have to give the incision. Okay, and you have to make you have to elevate the flap anteriorly, posteriorly, and you have to remove the subcutaneous tissue, and you have to sural nerve is preserved. Very important point. Here you have to preserve the sural nerve. Okay, so like that you have to make. If suppose second stage is needed, okay, still remnant subcutaneous tissue is lymphatic tissue is present, you can go for second operation usually 3 to 6 months later. Okay, so while in that doing second operation, you should not give the incision on the lateral aspect. Okay, that is a procedure. Then minimally invasive version came for Contolian procedure. Okay, so when we have to give this minimally invasive is the initial conservative treatment of pitting lymphadenoma to remove excess fluid, followed by liposuction to remove remaining excess volume bothersome to the patient. Okay. Then Charles procedure. Then you go for another procedure, Charles procedure. What is Charles procedure? So when you have to go for Charles procedure is when lymphedema is extremely pronounced. Okay, very large lymphedema and the skin is unhealthy and infected. Okay, the simple reduction operation Contolian is not adequate. Then you have to go for the Charles procedure. Okay, so the skin is healthy, you can go for Contolian or Homan. Skin is unhealthy or any infection is there, then you can go for Charles procedure. Okay, this procedure involves complete and circumferential excision of the skin subcutaneous tissue and deep fascia. Skin subcutaneous deep fascia of the involved leg and dorsum of the foot. Okay, so it is usually performed in one stage. This coverage is provided preferably by full thickness grafting. Okay, from the excisional skin. Okay. So what is the disadvantage? Okay, what is the disadvantage of the Charles operation is the wound infection, hematoma, and necrosis of the skin flap. Okay, so necrosis of the skin flap. Suppose the graft segment do not take 15 to 15%, 10 to 15% of the grafted segments do not take and can be difficult to manage because of frequent localized sloughing. Okay. Frequent localized sloughing. So frequent localized sloughing. How to overcome this skin problem is, okay, you have to take a split thickness skin graft from the opposite extremity to cover this area. Okay, these complications seem to be worsened in patient with whom leg resurfacing is performed with the split thickness graft from the opposite extremity. Okay, so they're telling that this sloughing, scarring, and focal recurrent infections are more common in patients with those who have done split thickness graft from the opposite extremity. Okay, so in case of advanced exophatic changes with the grafted skin, chronic cellulitis, skin breakdown may evenly lead to leg amputation. These are the various procedures. What do you have to know about the Contolian or Homan? Okay, next about Charles. Okay, and what is chylothorax? The chylothorax is so usually secondary to already the causes. So how to diagnose? The presence of chylomicrons on lipopet analysis and triglyceride level of more than 110 is the pleural fluid diagnostic. Okay, initially the patient is non-operative with a tube thoracostomy and medium chain triglyceride diet and a TPN. Okay, after that, the many therapies are there. Okay, so then you go for intervention. So when this conservative therapy not working for 1 week, okay, so the disease is still present even after 1 week with the conservative therapy, you can go for intervention. How can intervene? We can go for video assisted VATS therapy, thoracotomy, okay, and the new endoluminal method I have described, okay, and it's becoming the optimal first approach, and it's become the optimal. Okay, the new endoluminal techniques has been introduced and they become the optimal first approach for the management of persistent postoperative chylothorax. Okay, so what is the technique? How the approach starts? The approach starts with the lymphangiography. First, you have to take the lymphangiography. Okay, so lymphangiography you have to take. After that, you have to identify the cisterna chyli. Okay, in the cisterna chyli, you have to enter the cisterna chyli percutaneously. You inject the dye. Okay, and you have to inject the dye and you have to trace the where the lymphatic duct is injured. Okay, and you have to embolize. Okay, just percutaneous injection of embolization technique only. Okay, so first you have to do lymphangiography. You have to identify cisterna chyli. Okay, then you have to percutaneously you have to assess and insert the catheter, and you have to embolize the duct wherever it is injured. More than 50% success rate. Okay, it can more than 50% success rate. Okay, so for patient with cancer-related chylothorax or persistent drainage despite optimal chemotherapy and radiation therapy, fluorotaxis is highly successful in preventing recurrence. Okay. Okay. So in case of thoracic injury, okay, thoracic injury while doing surgery, you can go for this technique. Okay, Rabo techniques. In case of cancer-related chylothorax, the fluorotaxis is more beneficial. MCQ and chyloperitoneuum. What is chyloperitoneuum? Okay, this is where you have to know what the cause. What is the most common cause of chyloperitoneuum in case of children? In case of adults. In case of children, it is congenital lymphatic abnormality. In case of adults, it is malignant disease involved in the abdominal lymph node. Okay. Okay, the diagnosis is similar like that of chylothorax. Chylomicrons should be present at the triglyceride level more than 110. The initial treatment includes paracentesis followed by same.
Not audible.
Hello? How? So initial treatment. Initial treatment consists of similar like you have to go for the conservative treatment only, and giving paracentesis followed by medium chain triglycerides, okay, and diet or TPN. Okay, suppose the patient not respond this treatment after 1 to 2 weeks, then you go for percutaneous embolization or surgical exploration. Okay. So usually they told before 1 to 2 weeks, okay, you have to give a gap. For some conditions, you have to wait up to 4 to 6 weeks. What are the conditions? The congenital and malignant cause should be given longer periods of up to 4 to 6 weeks of non-operative management. Okay. So at the time of exploration, control of the leak can be achieved by ligation of the leaking lymphatic vessels or resection of the bowel associated with the leak. Suppose patient with the malignant neoplasm should receive aggressive treatment. Not that much important. The next we go to the tumors of the lymphatics. The tumors of the lymphatics, lymphangioma are the lymphatic analogs of the hemangioma of blood vessels. Okay, they are generally given two types. One is simple capillary hemangioma, another one is cavernous hemangioma or cystic hygroma. Okay, the another name of cystic hygroma is cavernous lymphangioma. Okay. Okay. So what is the majority of this? Majority of these benign tumors, these are benign tumors and present at birth. 90% of them can be identified at the So 90% of them can be identified by the end of the first year of life. Okay. So very important points. The cavernous hemangioma almost invariably occur in the neck or the axilla and very rarely in the retroperitoneum. Similarly, like the simple capillary hemangioma tend to occur subcutaneously in the head and neck and the axilla. Similar like only. Okay. Rarely, however, they can be found in the trunk with the internal organs or the connective tissue in and about the abdominal or thoracic cavities. Okay. So where the cavernous lymphangioma is present and where is the simple capillary lymphangioma is present. Just remember. Okay. So the treatment is surgical excision. Next, we'll go to the lymphangiosarcoma or Stewart-Rivers syndrome. Is a rare tumor complication of long-standing lymphedema. Okay. So this is a complication of lymphedema, not because of the radiation in breast carcinoma. Okay. So what is it? Usually more than 10 years. Okay. Long-standing lymphedema causes long-standing lymphedema more than 10 years. Okay. So clinically it's present as a nodules that have a propensity towards hemorrhage and ulceration. Okay, it should be treated like other sarcomas. What you have to do, you have to give preoperative chemotherapy and radiation followed by surgical excision, and which usually take the form of radical amputation. Okay, what is surgery you have to do is radical amputation. So overall, the tumor has very poor prognosis. Very small chapter. Okay.
இதோட பெய்லியில பெருசா இருக்குன்னு நினைக்கிறேன் சாப்டர்.